Welcome to the very first episode of MedScroll Clinical Case Files, where we bring real-world complexity into sharp clinical focus, one long case at a time. We're kicking off the series with a case that captures the depth and nuance of modern chronic disease management. Meet Mr. Albert Black, a 65-year-old gentleman with end-stage kidney disease on long-term hemodialysis, secondary to diabetic nephropathy and hypertension. His clinical journey is shaped by tertiary hyperparathyroidism, renal osteodystrophy, osteoporosis, renal anemia, and medically managed multivessel coronary artery disease. Layered onto this is a prior ischemic stroke with residual weakness, insulin-dependent diabetes with microvascular complications, and a fraught vascular access history, all culminating in a turning point conversation about care limitations and resuscitation preferences. In this premiere episode, we'll walk you through a full RACP-style, long case presentation, followed by structured examiner discussion, model responses, and reflections on multidisciplinary care, patient autonomy, and the art of navigating complexity. So grab your stethoscope and join us as we begin this journey into clinical reasoning that transforms complexity into clarity.
Good morning. I would like to present Mr. Albert Black, a 65-year-old European gentleman on long-term hemodialysis for end-stage kidney disease, secondary to diabetic nephropathy and hypertension. His case is complicated by tertiary hyperparathyroidism with renal osteodystrophy, renal anemia, osteoporosis, multivessel coronary artery disease managed medically, a prior ischemic stroke with residual weakness, insulin-dependent type 2 diabetes mellitus with microvascular complications, and dyslipidemia. He has a challenging vascular access history and is approaching a point of considering future care limitations, including his resuscitation preferences. He has previously been assessed for transplantation, but was deemed unsuitable due to significant cardiovascular comorbidities and cerebrovascular disease. Mr. Black first developed chronic kidney disease in 2012, identified during routine monitoring of his diabetes and hypertension, with an initial eGFR of 60 milliliters per minute per 1.73 square meters. Over the following 5 years, despite reasonable control of his diabetes and blood pressure, his renal function steadily declined, reaching stage 4 CKD by 2017. By mid-2017, he developed progressive uremic symptoms, including anorexia and fatigue, prompting initiation of hemodialysis. He commenced dialysis via a tunneled right internal jugular catheter, as peritoneal dialysis was not feasible due to prior abdominal surgery and personal preference. His vascular access journey has been particularly challenging. An initial left radiocephalic AV fistula thrombosed early, followed by failure of a brachiocephalic fistula due to poor vessel caliber. After exhausting upper limb options, a right brachioaxillary AV graft was successfully placed 18 months ago. He has experienced 2 episodes of catheter-related bloodstream infections, including an MRSA bacteremia requiring ICU care. His current dialysis regimen consists of thrice-weekly hemodialysis, each session lasting 4.5 hours. His target dry weight is 72 kilograms, and he typically achieves this with 2.5 to 3.0 liters of ultrafiltration per session. He generally tolerates dialysis well, with occasional post-dialysis fatigue but no recurrent intradialytic hypotension. His post-dialysis blood pressure remains within target at around 120 to 130 over 70 to 80 millimeters of mercury. Mr. Black developed tertiary hyperparathyroidism with persistently elevated PTH despite medical therapy. 2 years ago, at age 63, he underwent subtotal parathyroidectomy. This was complicated by postoperative hypocalcemia and hungry bone syndrome, requiring prolonged inpatient calcium replacement. His bone mineral disorder is further complicated by severe osteoporosis, confirmed by a DEXA scan showing a lumbar spine T-score of -3.2. He is on denosumab 60 mg subcutaneously every 6 months, daily calcium carbonate 1 gram 3 times daily with meals, and vitamin D3 1000 IU daily. Cinacalcet was discontinued following parathyroidectomy. Consistent with ESKD, Mr. Black has renal anemia, which is managed with darbepoetin alpha administered weekly, with dosing titrated by the dialysis team. He also receives monthly intravenous iron sucrose infusions during dialysis to maintain adequate iron stores. His hemoglobin target remains between 100 and 115 grams per liter, with careful monitoring to avoid overtreatment and cardiovascular risk. Diagnosed at age 48, his diabetes has contributed significantly to his renal disease. There is a family history of diabetes in his brother. Mr. Black is on a basal bolus insulin regimen with insulin glargine 32 units at night and insulin aspart 3 times daily with meals. His glycemic targets are adjusted for his ESKD status, aiming for an HbA1c between 7% and 7.5% to balance risks of hypoglycemia and vascular complications. He has evidence of diabetic microvascular complications, including stable peripheral neuropathy and a previous diabetic foot ulcer that healed following debridement and VAC therapy. He has also undergone cataract surgery, and retinal screening remains stable. Foot care is maintained through regular podiatry and endocrinology follow-up. Mr. Black has significant cardiovascular disease. At age 58, he was diagnosed with multivessel coronary artery disease, confirmed on angiography to involve the LAD, RCA, and circumflex arteries. He was assessed by the cardiac team and deemed unsuitable for revascularization due to poor graft targets and high surgical risk. His management remains medical with bisoprolol 5 mg daily, isosorbide mononitrate 60 mg daily, and atorvastatin 40 mg nocte. He suffered an ischemic stroke in the right MCA territory at age 61, resulting in mild residual left-sided weakness and dysarthria. Carotid Doppler imaging demonstrated stable 60% left internal carotid artery stenosis. Hypertension, controlled on triple therapy with amlodipine 10 mg daily, bisoprolol, and isosorbide mononitrate. Dyslipidemia, managed with atorvastatin. Gout, stable on allopurinol 300 mg daily with no recent flares. Peripheral neuropathy secondary to diabetes. Chronic hepatitis B carrier status. Surface antigen positive with DNA undetectable on antiviral suppression. History of depression, previously treated, currently stable without pharmacotherapy. Prior diabetic foot ulcer fully healed. Mr. Black is married, with his wife serving as his primary carer. They live in public housing with wheelchair access, and he receives support through the NDIS, including a support worker twice weekly. His 2 adult children live interstate and maintain regular contact. He is a former truck driver, retired due to health complications. He quit smoking at age 50 after a 30-pack year history and drinks alcohol occasionally. Psychosocially, he reports feelings of frustration over his dependency and concerns about being a burden on his family. Advanced care planning discussions have been initiated, and he has indicated that he is currently not for intubation or ICU level care, but remains open to revisiting these decisions. Mr. Black is cachectic and wheelchair-bound, but alert and cooperative. His cardiovascular exam shows dual heart sounds without murmurs, normal JVP, and weak but palpable pedal pulses. Respiratory exam is clear. His abdominal exam is unremarkable with a palpable functioning AV graft in the right upper limb. Neurological exam reveals mild left-sided weakness and dysarthria, consistent with his stroke history. There is thoracic kyphosis and mid-spine tenderness, but no evidence of recent vertebral fracture. Peripheral neuropathy is present in the lower limbs, and feet are intact with no ulcers. Mr. Black presents with ESKD on hemodialysis with vascular access complications, tertiary hyperparathyroidism post-parathyroidectomy, complicated by osteoporosis, renal anemia, managed with ESA and IV iron, type 2 diabetes mellitus with microvascular and macrovascular complications, coronary artery disease with multivessel involvement managed medically, ischemic stroke with mild residual deficits, hypertension, dyslipidemia, stable gout, peripheral neuropathy, and chronic hepatitis B. Psychosocial vulnerability with progressing frailty and advanced care planning considerations. Dialysis and vascular access. Continue thrice-weekly hemodialysis via right AV graft. Ongoing graft surveillance. Avoid further central lines where possible. Education on infection risk and vascular access care. Tertiary hyperparathyroidism and osteoporosis. Maintain denosumab, calcium carbonate, and vitamin D3. Regular monitoring of calcium, phosphate, and PTH levels. Falls risk assessment and physiotherapy. Renal anemia. Continue darbepoetin alpha and IV iron sucrose. Monitor hemoglobin and iron indices monthly. Type 2 diabetes mellitus. Maintain current basal bolus insulin regimen, ongoing podiatry, endocrinology, and ophthalmology follow-up. Cardiovascular disease. Continue medical therapy, beta blocker, nitrate statin, blood pressure and lipid management. Secondary prevention, BP, lipid control, diabetes management, physio support for residual deficits, annual carotid Doppler monitoring. Other medical issues, continue gout prophylaxis and hepatitis B monitoring. Address peripheral neuropathy symptomatically. Continue advanced care planning discussions. Engage social work for care support and NDIS coordination. Consider palliative care input to support symptom management and care planning. Thank you.
What are the key causes of anemia in end-stage kidney disease, and how do they influence your management strategy in this patient?
The anemia in ESKD is multifactorial. The primary driver is erythropoietin deficiency due to reduced renal synthesis. Additional contributors include functional iron deficiency due to chronic inflammation, hepcidin-mediated iron sequestration, blood losses during dialysis, reduced red cell lifespan, and nutritional deficiencies such as folate or B12. In Mr. Black's case, he is managed with darbepoetin alpha and IV iron sucrose to address EPO deficiency and ensure iron availability. Regular monitoring of hemoglobin, iron studies, ferritin and transferrin saturation, and avoiding overcorrection, target HB approximately 100 to 115 grams per liter, are critical, as higher targets may increase cardiovascular and thrombotic risks.
Discuss the pathophysiology and management options for tertiary hyperparathyroidism in dialysis patients. How is this addressed in Mr. Black's case?
Tertiary hyperparathyroidism arises from prolonged secondary hyperparathyroidism, where parathyroid hyperplasia becomes autonomous. In ESKD, reduced phosphate excretion, low calcitriol, and hypocalcemia drive persistent PTH secretion. Management includes phosphate control, dietary restriction, phosphate binders, vitamin D supplementation, active forms like calcitriol or cholecalciferol, calcimimetics, e.g. cinacalcet to reduce PTH secretion, surgical parathyroidectomy when refractory to medical management, as in Mr. Black's case. Post-parathyroidectomy hungry bone syndrome, seen in Mr. Black, reflects rapid bone remineralization and requires intensive calcium and vitamin D replacement.
What are the specific cardiovascular risks in dialysis patients, and how does this affect decision-making around revascularization and medical therapy?
Dialysis patients face accelerated atherosclerosis, vascular calcification, and left ventricular hypertrophy. Risks include coronary artery disease, CAD, arrhythmias, and sudden cardiac death. Mr. Black has multivessel CAD, but revascularization was deemed high risk due to poor targets and comorbidities. Medical therapy remains cornerstone. Beta blockers, bisoprolol for rate control and anti-angina effect. Long-acting nitrates for symptom relief. Statins, atorvastatin, though benefit is mainly for primary prevention before dialysis initiation. Careful BP and volume status management are also critical to reduce cardiac workload.
How do you approach glycemic control targets and insulin management in dialysis-dependent type 2 diabetes?
Glycemic targets in ESKD are adjusted due to reduced insulin clearance and risk of hypoglycemia. HbA1c targets of approximately 7 to 7.5% are appropriate. In Mr. Black, basal bolus insulin regimen, glargine and aspart. Monitoring capillary blood glucose, especially around dialysis sessions. Awareness that HbA1c may underrepresent glycemia due to shortened red cell lifespan. Consider adjunctive measures like fructosamine if indicated. Education on hypoglycemia recognition remains key, despite no current unawareness.
Outline the complications of vascular access in hemodialysis and your approach to managing access failure.
The ideal access is an AV fistula followed by AV graft, with catheters being last resort. Mr. Black has a right brachioaxillary AV graft following multiple failed fistulas. Complications include thrombosis, stenosis, often at the anastomosis or outflow tract. Infection, high iron grafts and catheters, MRSA bacteremia history in this patient. Management involves Doppler surveillance of graft flow, prompt intervention for access dysfunction, angioplasty or surgical revision, rigorous infection prevention and education on access care.
What are the main causes of bone disease in ESKD, and how do you decide on pharmacological treatment?
Bone disease in CKD, termed CKD-MBD, includes high turnover, secondary tertiary hyperparathyroidism, low turnover, a dynamic bone disease, and mixed forms. In Mr. Black, osteoporosis was confirmed by DEXA, post-parathyroidectomy. Pharmacological choices in CKD include denosumab, preferred in ESKD as bisphosphonates are renally cleared. Calcium plus vitamin D supplementation, monitoring calcium, phosphate, and PTH regularly. Denosumab is monitored for hypocalcemia risk, especially post-parathyroidectomy.
What factors determine transplant eligibility in dialysis patients, and why was this patient deemed unsuitable?
Transplant eligibility considers age and physiological reserve, comorbidities, CAD, stroke, frailty and functional status, active infections or malignancy. Mr. Black was excluded due to multivessel CAD, not amenable to revascularization, prior stroke and frailty, predicting poor surgical risk and graft outcomes.
How do you assess dialysis adequacy, and what adjustments might be considered if this patient becomes increasingly symptomatic?
Dialysis adequacy is typically assessed using KT/V or urea reduction ratio. Inadequate dialysis manifests as persistent fluid overload, uremic symptoms, or poor appetite. For Mr. Black, monitor session KT per V, target greater than or equal to 1.2 per session. Consider extending session duration or increasing frequency if inadequate. Assess fluid status, interdialytic weight gain, and ultrafiltration rate. Nutritional review and adjustment of dialysate prescription as needed.
What are the key elements in assessing functional status and quality of life in a dialysis-dependent patient like Mr. Black?
In assessing functional status, I would explore Mr. Black's ability to perform activities of daily living, ADLs, such as mobility, toileting, self-care, and meal preparation. I would also assess instrumental ADLs, including managing medications and finances. Given his wheelchair dependence and post-stroke weakness, I would focus on his fall risk, muscle strength, and endurance. Quality of life assessment would include impact of dialysis schedule and fatigue on daily life, symptom burden, pain, sleep quality, appetite, emotional well-being, including mood and frustration related to dependency, social connectedness and support systems. I would use tools like the KDQOL-36, Kidney Disease Quality of Life Questionnaire, where appropriate.
How would you approach advanced care planning and resuscitation discussions with Mr. Black and his family?
Advanced care planning should be an ongoing, sensitive conversation framed around Mr. Black's values, goals, and understanding of his prognosis. I would explore his wishes regarding life-prolonging treatments like CPR, ICU admission, and intubation. Scenarios where aggressive intervention may not align with his goals, e.g., irreversible loss of function or quality of life. The role of substitute decision-makers, ensuring his wife and children are part of the discussion with consent. I would use clear, empathetic language, avoid medical jargon, and offer written resources, or involve a palliative care specialist to support these discussions.
What psychosocial challenges are common in long-term dialysis patients, and how can they be addressed in this patient's context?
Psychosocial challenges may include depression, anxiety, and frustration related to loss of independence, financial strain due to early retirement and healthcare costs, carer fatigue, particularly for his wife, social isolation due to reduced mobility and time commitment to dialysis. In Mr. Black's case, I would offer social work referral for financial advice and carer support, counseling or mental health services, connecting him with peer support groups for dialysis patients, exploring community engagement options within his capabilities.
How would you coordinate multidisciplinary care for this patient, and who should be involved?
Given the complexity of Mr. Black's care, key team members would include nephrologist and dialysis nursing team for dialysis adequacy and access monitoring, cardiologist for CAD management, endocrinologist for diabetes care, physiotherapist for mobility, strength, and fall prevention, podiatrist for diabetic foot care, dietitian for phosphate, calcium, and fluid management, social worker for carer support, financial aid, and NDIS coordination, palliative care team for symptom control and advanced care planning. Effective communication between these providers, ideally through shared care plans and case conferencing, would be essential.
What educational strategies would you use to improve this patient's understanding and self-management of his vascular access?
Education would focus on recognizing early signs of infection, redness, warmth, discharge, and thrombosis, reduced thrill, swelling. Teaching safe hygiene practices around the graft site, emphasizing the importance of avoiding blood pressure measurements and blood draws on the graft arm. Reinforcing the need for prompt reporting of access issues to the dialysis team. I would tailor the education to Mr. Black's learning preferences, use diagrams, written materials, and involve his wife to reinforce understanding.
How would you support the primary caregiver, his wife, to reduce carer strain and promote sustainability of home supports?
Support strategies would include referral to social work for care assessment and access to respite care options. Ensuring she is aware of available NDIS supports, encouraging participation in carer support groups, providing psychological support or counseling if needed, facilitating family meetings to discuss care roles and share the burden where possible. It is important to recognize caregiver well-being as a critical component of Mr. Black's care plan.
Discuss the role of palliative care in chronic kidney disease and how it may apply to Mr. Black.
Palliative care in CKD focuses on symptom management, pain, breathlessness, pruritus, fatigue, psychological and spiritual support, advanced care planning, and family discussions. For Mr. Black, palliative care can assist with decision-making around future care intensity, including the possibility of transitioning to conservative non-dialysis management if his condition worsens. Importantly, palliative care should be integrated alongside active treatment, not only at end of life.
What are some potential barriers to adherence with complex medication regimens in ESKD, and how would you address them?
Barriers may include high pill burden, cognitive overload or forgetfulness, financial limitations affecting medication access, lack of understanding of medication purpose, strategies to improve adherence, pharmacist medication review to simplify regimens, use of blister packs or pill organizers, education around the rationale for each medication, involving his wife in medication supervision, checking health literacy and providing written instructions. Regular review and reinforcement during dialysis visits are also important.
Thanks for joining us on this very first episode of MedScroll Clinical Case Files. Mr. Albert Black's case reminds us that beneath every long-term diagnosis lies a story of resilience, evolving goals, and complex decisions. From the intricacies of renal replacement therapy to the ethics of care planning, this case offered rich ground for clinical reasoning and reflective practice. If you found this episode insightful, don't forget to like, subscribe, and hit the bell icon so you never miss an update, because we're just getting started. Drop a comment below with your thoughts on the case, what you'd do differently, or what topics you'd like us to explore next. This is MedScroll, bringing clinical complexity into focus, one case at a time. See you in the next episode.